Welcome to the Fast Track Cities Getting to Zero podcast. This month, we're celebrating the contributions and experiences of women in the HIV community. The women who have shaped HIV care, driven support initiatives, and of course, women living with HIV who continue to inspire, lead, and advocate with strength and resilience. Did you know the first cases of HIV in women were reported as early as 1981, but women were often underrepresented in clinical research for decades? In 1990, ACT UP activists protested the CDC to expand its definition of AIDS, which finally recognised the unique ways HIV presented in women. Today, women account for over half of all people living with HIV globally, yet their stories are still too often unheard. Women living with HIV face unique challenges, from stigma to access to healthcare to balancing care responsibilities and navigating relationships. In this episode, we speak to two powerful voices working within the HIV community, Angelina Namiba and Dr. Laura Waters. They share their experiences, insights, and ongoing work needed to support and uplift women in HIV today. First, we hear from Angelina Namiba, a long-term advocate, speaker, and community leader, who shares her personal journey and why peer support is such a vital part of living well with HIV.
My name is Angelina Namiba, and I am originally from Kenya, but I've been living in the UK for a very long time. I think more than half of my life, probably about 32 years, which is way more than half of my life. I'll let you do the maths for that. And I am one of the founder members of the Forum Network. So Forum stands for My Health, My Choice, My Child, My Life. It's a perinatal peer mentoring project working with mentor mothers living with HIV to support them, for them to train, mentor, skill them up to support their peers going through the pregnancy journey and beyond, but also for their own personal development. And you'll notice that I said working with mentor mothers, because everything, all our projects, all our programs, all the work that we do is directly informed by women living with HIV. The charity is very small. It's a community interest company, and it is led by 3 migrant women living with HIV. Yeah. Our bread and butter really is training and support. But we also, at the moment, we have a program called, we call it Date Nights, Each One Teach One. So these date nights are psychological group support sessions, but really the way the sessions go is we have monthly online group support sessions, because some of our members are based in London, some are based in some areas of the UK, and we also have mentor mothers who are based in East Africa as well, and some few in Southern Africa. So, for example, the program called Date Nights, Each One Teach One, it is about the first hour of the group support session, which is online, is facilitated by a trained clinical psychologist, and who they offer their time pro bono. But the session is facilitated by our mentor mothers. And then within that, we have a small creative element. And then we also have a mindfulness session, which is led by mentor mothers living with HIV, some of our mentor mothers. And so this is one of the projects that we're working on at the moment. We're going to be working on some more projects. So that's group support, but which has a psychological support element to it, because we found that, of course, women living with HIV face many issues. There's the issue around being diagnosed in pregnancy and worrying about treatment for yourself, how it's going to affect you, how it's going to affect your baby. There's issues around some of the women diagnosed with HIV. Because women are diagnosed first, may take the diagnosis back to the home. Some of them experienced domestic violence. There's issues around mental well-being. There's issues around maybe you have children before your diagnosis, having to test the children and finding out whether the children are okay. So many other issues. There's issues around immigration. There's issues around poverty. There's issues around housing and homelessness. There's so many issues. And so inevitably women do face some mental health issues. So their mental well-being is not necessarily going to be as good as it should be. And we know that in this country and many other countries, to be fair, access to clinical psychology or to mental health support is not always easy because, of course, there's so many more people who need that support. And so within this project, we are very lucky that we actually have access to a psychologist who the women can have access to as a group session. So they do lots of different things. Apart from facilitating the session, they also do presentations about living well, about sleep, around relationships, so many things. And the issues are all informed. Women tell us we would like the clinical psychologist to cover this, and then we have a discussion. That's one of the projects that we do. But we also work closely with researchers and, depending on how they would like to be involved. What I failed to mention was that actually, although we are led, not although, we are led by 3 migrant women living with HIV, but we also have a wonderful steering group of clinicians and researchers who kind of do guide the project. So it's our steering group. And so we have amazing people on that team. So we are guided by them, but we also have our women, but we also work with the mentor mothers directly to inform our projects. So yeah, there's more that we do, but I think maybe it's better if you share the website and people can have a look to see the group support, the workshops. We have also collaborated with the Good Things Foundation, particularly started during the COVID times. And what they do is they offer, mm, they noticed that there's a huge, especially during COVID, that there was a huge gap in terms of there was data poverty amongst a lot of communities. So we work with them and they support us toward giving us sometimes devices for the women who are, not able to afford them, but also data bundles so that women who attend the date nights or any group support sessions that are online can have data bundles towards the 2-hour session without necessarily being out of pocket. One of the first preconceptions or misconceptions is that people often assume that women living with HIV must have been promiscuous to actually get HIV. But of course, we know that that's not necessarily the case. HIV, I always say it's an equal opportunities illness. It can affect anybody. And of course, there are many, I think more than half of the people living with HIV in the world are women. But then, of course, just by the nature of who we are, sometimes we are disproportionately affected by HIV because of so many circumstances. So that's one myth and misconception, that you have to have been promiscuous to have HIV. It's just not the case. There are many circumstances that lead to women being diagnosed with HIV. The other misconception is that people often assume that HIV only affects either Black or African women. Again, this is not true. Of course, more women living with HIV are from the African continent. However, HIV affects women from across the globe. So that's another misconception. And I think that's one of the reasons why we know over the years, many women from non-African backgrounds have not been offered the HIV test, or indeed their HIV has been picked up much later, because even though they presented at healthcare services with maybe HIV defining illnesses, they were not offered a test because the healthcare providers presume or assume that you're not from Africa, so you cannot have HIV, so I'm not going to offer you the test. So that's the second misconception. The other misconception is that, and this is, I think, much more societal and stigma related, is the fact that people often assume that women living with HIV, can't have children, or can't have children born without HIV, or can't have children naturally, i.e. vaginally, or cannot breastfeed their children. But we know that HIV has changed over the years, and the case might have been so in the beginning, but now things have changed so much. We have this concept called U equals U, which means undetectable equals untransmittable. I mean, I guess in layman's terms, that means that if somebody living with HIV takes the HIV medication on time and as recommended, and achieves and maintains an undetectable viral load, which means that their HIV is very well controlled, it means they cannot pass HIV on to either a sexual partner or to their unborn child. So guidelines have changed so much more that, so once a woman has an undetectable viral load during pregnancy and by the time they're delivering, if the choice is to breastfeed, they can be supported to do so safely. But of course, it's important that they engage with services and do the tests that are needed and be monitored as is expected. The other misconception is that women living with HIV cannot have relationship or cannot have sexual relationships. Again, this is another huge myth and misconception. And I guess a lot of it is also partly a lot of societal judgment and stigma and morality, you name it. I always say HIV is a virus, it's not a moral issue. But I mean, I guess in a way, a lot of society thinks that way. But then also there's a thing about perhaps when women are first diagnosed, some then decide that I'm never going to have a relationship because it's because of having a relationship that I have HIV for many of them. But later on, when they get the support that they need, oftentimes, of course, they change that. And I know so many women who have been in relationships, either with other people living with HIV or not, because you always say you can't limit yourself. You can't just self-select and go out with people living with HIV because you have the same virus. Because actually, having the same virus doesn't make you a good person necessarily or a bad person. So yeah, but over the years now, of course, it's just about getting the support, the information that you need to know that you're still a sexual being, you're still attractive, you're still a human being. Having a relationship is your very basic human right. So that's really important. Of course, there are women who choose not to have relationships and just have cats, which is absolutely fine. But I think the misconception about, we shouldn't have children or we shouldn't have relationships is quite wrong. So yes, women with HIV can have relationships if that is what they choose. And the last one I'm going to share, which I think is a misconception, but also maybe the opportunity is not there. There are many more, but I'm only sharing this because otherwise we'll be here until tomorrow, is the fact that women living with HIV are not capable of engaging in research or clinical trials or such studies beyond being participants. But actually, what researchers often forget is the fact that women living with HIV who are participating or who are participants in trials are also doctors, they're also nurses, they're also clinicians, they're also teachers, they're also community leaders. And the fact that they can be involved not just as participants, but also throughout the life cycle of studies. And to this point, a group of myself, other women living with HIV, and clinicians who are part of the forum network, we got together and we wrote a paper called From Presumptive Exclusion to Fair Inclusion, which is perceptions on the involvement of women living with HIV in clinical trials, which includes stakeholder views. This is a paper that was published in February 2022. And it just highlights the importance of involving women meaningfully, not just as participants, but also as part of trial teams and as part of co-authors and part of the dissemination team. And just, yeah, we can do more. We're just like everybody else. We're moms, we're sisters, we're lovers, we're friends, we're workers. Yeah. And with the right access to treatment, to care, and to support, yeah, we can lead just regular lives. Yeah, so I guess community can refer to a lot of things. It can be the healthcare providers, it can be social care providers, it can be faith communities, it can be your family, the community around you, it can be HIV support organizations. So community organizations or community are really vital in providing the crucial support that women need, covering all the different areas and issues that I mentioned. Um, so I guess one way they can do this is they can facilitate access to health and social care and also to access to treatment depending on where you live. Again, what I've already mentioned is they can, facilitate access to psychosocial and peer support. Peer support is incredibly important to women living with HIV. It's what got me where I am today. I was very lucky to access peer support earlier on in my diagnosis, and so that has always been, and that's why I think I still do a lot of work around peer support because I know how valuable it was for me. Um, but communities can also enable like economic empowerment for women. So by supporting women to start women business led initiatives and, being able to get the information that they need to do startups, to be economically independent. Because one of the issues I know about the fact that some women are not able to be open about the status and why stigma affects them is the fact that many are both emotionally and economically dependent on their families or partners or significant others. And so making a choice to be open about the status is not really up to them because it can mean the difference between having a home and not having a home. Because if you're dependent on somebody for everything, they can throw you out of the house. And we have worked with women who've experienced that. And so, if where women can have economic empowerment, it means that they can stand on their own feet and they can actually, get on with their lives, really. But also in terms of communities, because a lot of stigma is down to misinformation, lack of awareness, but also the fact that governments in some countries are actually really quite punitive towards people living with HIV and women living with HIV. And so I've worked with colleagues and friends who live in countries whereby they cannot even exercise their basic human rights, of either just living as women living with HIV or having children or having relationships, because there's a lot of issues around criminal potential for being criminalized or being prosecuted just for being who you are. And so communities can advocate for better human rights laws in place and to actually make the women aware of what their rights are and the way they can go to support where they experience any this kind of legal or human rights violations or discriminations. But communities are really, really important. And this is where you look at the wider community in terms of where we live, in terms of faith communities, because they have the potential to actually raise awareness about HIV, to enable inclusion. And by doing that, it means they can go a long way in terms of tackling stigma, because we know there's some faith communities, not all of them, who are not necessarily very welcoming to people living with HIV, but actually where faith leaders, but we've also worked with incredible faith leaders from the different faith communities who are very aware and who preach the right message within their different congregations. And so where they do that, it means that people within the congregation feel safe and heard and supported. And so they can challenge the stigma from that angle. Yeah, so I think, communities are really important. And by really meaningfully engaging women living with HIV, and enabling them to access all these, the health, the social care, and economic empowerment, communities can really enhance self-reliance as well as reduce the stigma as much as is possible, and promote the well-being of women living with HIV, and just let us live our best lives, really. And I think it's also important for women living with HIV to know that community is really wide. Apart from the faith communities, there's also HIV support organization. They can access support there. They can access support from the clinic, because some women only go to the clinic, but the clinic can also refer you on or tell you about what is available in your local community where you can go for peer support. Local libraries and local events have things that they're not necessarily related to HIV, but they're connected to your well-being. So, for instance, there's a program that I joined. I don't know if you've had it. Obviously, there's been in the news a lot about the YMCA closing down, which is a place that was a sanctuary and safe for a lot of us living with HIV. The Positive Health Scheme was amazing. I've been going there for so many years, but it shut down, and a lot of people are having to think about, oh, where else can I go? Because of that, mm, the peer caseworker at Mortimer Market, I have to give him a shout out. His name is Fernando. Says, no, I understand this happened, but do you know that you can go to your GP and get referred to a program within your local area? I said, no, I did not know that. So I did go to my GP, got an appointment with a health advisor there, and they referred me to a program called Better Together. And I believe this program is available in different boroughs, whereby you can get access to like a health and well-being program. So you get nutrition advice and exercise, and then you have access to all the health centers. So I have access to all the health centers for 3 months. I pay a small fee towards like the membership, and then I can get access to all facilities within Hackney. So I'm actually planning to, within that time, try, because I used to go to the Y to swim because I can't do the gym. I'm not a gym bunny. So I'm going to try. My plan is to try and swim in every single swimming pool in Hackney, and then I'll choose one that I like and I'll stick to that. That's the plan and that's the theory. Ask me again in a few months' time whether I've actually managed to accomplish that. But so there's all those things that are around and available within the community. But there's also so many online webinars and trainings and group support like the one I mentioned, our Each One Teach One. And the reason is it's called Each One Date Nights Each One Teach One is because it's about what we want to do is for the women who access, because we can't reach everybody, but we just ask the women who access the webinars and the date nights to something that they've learned to go and teach or tell one other woman so that that information cascades. I was at a conference the other day and just shared my experience of the menopause and brought along, I said I brought along some of my friends because one of the projects that NAS Project has done, but jointly with Forum, with Sophia Forum and with Positively UK, is a project called the Bearded and Flash Project, which is an irreverent and unapologetic way of looking at living with HIV and going through the menopause. And so I shared my story, but I also shared a short film of 4 different women living with HIV talking about how they cope with menopause on a day-to-day basis. And one of the questions somebody asked me was, what is this magic ingredient that keeps you and your friends going? And I said, well, the first magic ingredient is peer support. Once you have access to peer support, then, everything falls into place. But also important is the fact that a lot of these projects that do peer support is the fact that they're informed, they're led by the projects that are delivered by women living with HIV, and that's really, really important. So yeah, peer support is a magic ingredient. HIV can impact the relationships in different ways. It can either be in a good way or in a not so good way. So in terms of romantic, I think in terms of how it can be influenced is just the fact that it also depends on how confident a person is or how open they are about their status or how ready they are to share the status. But the thing is, when it comes to romantic liaisons, it's not always very easy to tell somebody about your status. Um, whereas, you know, every day, whereas people, when you're getting into a relationship, first, if you take HIV out of the picture, you just want to be your best self and you hope that this relationship is going to work. Is this person going to like me? Am I going to like them? Are we going to get on? That's what most people are thinking about, right? But with somebody living with HIV, then there's the added thing about, okay, now I need to tell them about my status. Are they going to accept me or not? And oftentimes you'll find that people focus very much on, are they going to accept my status? And when they do tell their status and the person accepts them, for many, they feel so relieved that they will stay in that relationship even if it's abusive or they're not being treated well. Because you know what, at the end of the day, this person accepted my status. So I always say just don't limit yourself. And there are many people out there who I know who've been in relationships with people who are not necessarily living with HIV. They've just accepted them for who they are. So that's one of the ways that could impact romantic relationships. There are many more, but there's just, you always have that extra thing to think about. In terms of family, I guess it's the same way, but then it's also about acceptance, because a lot of the stigma that is directed at people living with HIV, apart from the self stigma and the societal stigma, it's actually stigma that people experience within families themselves, which we've come across many women who've been thrown out of home. I remember meeting a woman who said that even though she was still living within the family home, they had segregated a cup, a plate, a spoon, cutlery for her to use because she had it. And every time she used the toilet, they would wipe, disinfect it. So there's that stigma that can be experienced within the family. But then equally, there's the fact that families can be really, really supportive. And I use the example of my own family, who once I told them have been like really supportive. My mom, my late mom, was the first person I told in the family. And this is the how not to tell your mother you have HIV. It was just, it's a long story, but cut it short, it was with kind of we're having an argument over the phone. And my mom had been diagnosed with bipolar and manic depression, but she thought, deteriorated over the years. And then my brother passed away and, it really, really affected her. So anyway, one time I'd gone to see her, but I left feeling even downer than was. Then I went in because my aim was to, try and lift her a little bit. Anyway, I say it's a short story, cut long story short. So I go back home and we're having this argument, and then she's talking about how she's, it's really things are affecting her, how she's down. And I'm like, I'm gonna, but Mom, I'm also ill. I'm on the phone. And then she goes, what's wrong with you? And then I go, I'm HIV positive. And then I thought, phew, I've told her. But then I thought, oh my goodness, what have I done? You don't tell your mother you have HIV over the phone. But my mom's reaction was, she just said, I wish I was near you to give you a hug. And for me, that I believe that set the tone for me going forward in terms of sharing my status. Because I thought if my mom is cool about it, then I don't really care what anybody thinks. And she remained supportive from that day on until the day she passed on, 2015. Then I told my brother, who was my favorite sibling in the family. Of course, I love all my siblings. But then when I told him, he said, "Oh, well, you're still my favorite sister." I'm like, "Oh, two down, then I'll move on to the next." So my family have been supportive. And I know, and I told my daughter when she was about 9, told her about my status because she was born without HIV. By the way, I'd like to give a shout out to my daughter. Her name is Hamza, HAMZAA. She's a singer-songwriter and she is absolutely amazing. Check her out on all the music listening channels. But so as I said, she was born without HIV, but I needed to tell her about my status. And I chose to tell her when she was quite young because I felt it was important for her to know. And by that point, I was open. And she was computer literate, so she would only have had to type in my name. She would have seen me there on the cover of some magazine. So, but I'm glad I told her then because I figured she was ready. But I know parents always grapple with this issue of telling their family or their children. But as a parent, as a carer, because some children are very mature at 7, some children are very immature at 16. So you gauge, and that's what I did. So for me, my family was very supportive, and I know many people who have been supported, but I know many who haven't. So it's just about, so it can have quite an impact because for me, my family was supportive, and that enabled me to move and be where I am because I think it's really important. But then some people haven't been accepted by the families, but what they've then done is created other families from within the community, from their friends. So it can be quite a big impact. And I think the same goes for friendships. My friends are cool. But then, in fact, when I was going for my test, I told one of my friends, lovely friend, Sissy, who lives in Germany, and she told me, let me know when you had the result. And I told her, and she's been supportive all these years. It's not been a big deal. So I think I've been very lucky. I've been surrounded by amazing people. In fact, the first person I told about my status had told me about her status. So I told her, and then she took me to a support group where I got peer support. So friends can be very influential and very supportive. In the same vein, friends can be not supportive. And I know people who've told friends who've then gone on and told other people about the status. But then I guess in a way, when you tell somebody, a friend, about your status and they misuse that information, then it also gives you an opportunity to see who are my real friends and who are not. And I always say you're better off having 1 or 2 really good friends who support you than having 20 or 30 or 40. It's not easy to get to that point, but I always say, if you tell somebody you have HIV and they don't like it, just ask yourself, do they pay your rent? Do they pay your bills? Do they feed you, your children? And if they don't, then you don't need them in your life. But I can say that because I have somewhere to live and I'm an amazing support network. I have a wonderful family, but there are others who don't. And so I say that with a caveat so that only those of us who are able to be open about our status safely should do so. And we don't expect everybody to do that. So, yeah. So that's how, HIV can impact on the different relationships. No right or wrong way to share your status with somebody. However, I think for me, the key thing is to be prepared as much as you can. There are a number of things you need to consider. So the first thing is, why are you sharing your status? Are you telling somebody because you've been forced to do it, or you feel that you have to do it, or, what is the reason why? And I've always said for years and years that you need to tell somebody your status from a position of power. That just means not that you're powerful. It just means that you own that information. And if you tell them in a way that they should feel, in a way, not lucky, but you're giving them privileged information, you're giving them information that is important to you. And so you're sharing it because you've chosen to share it. And that's not always the case for everybody. Sometimes your status inevitably gets out or somebody says something about you. So firstly, why are you telling somebody? And in an ideal situation, it should be your decision, not anybody else's. The other thing is thinking about how are you going to tell them, and where you're going to do it. And, just there's certain small things that you can think about. If you decide to tell somebody, what environment are you doing it in? I remember years ago, my friend, I think it was Julia, she used to say that if you're going to tell somebody, take them to the park and then tell them your status. And if they react badly, you can run off in the opposite direction. But yeah, that's just one way you can do it. Another friend said, and this is like, I think I really find this was really good. For example, if maybe you are starting a relationship or in a relationship, you can just tell them when you're in the kitchen making a meal, you're chopping the onions. By the way, this is my situation. However, I am living well with it. I take medication. I can't pass it on to you because it's much easier now to have that conversation because you can throw in straight away, I can't pass it on to you because I do this and that. Whereas in the earlier days, it was a little bit challenging because we didn't have EU equals you concept. I'm not saying it's everything, but it just makes that conversation easier. Yeah, just think about, as I said, the environment. If you're doing it, maybe make sure your mobile phone is on silent. You're not going to have any interruptions so that you can really have a conversation. But also just be very open about saying they can ask you questions. However, this is where you need to be prepared. You need to have the basic facts about transmission, about a bit about treatment, so that if you think about it, if you're telling somebody who has no idea about HIV, they're going to have questions. But also consider the fact that by sharing your status with somebody, it might be a big thing. It might be too big for them. They might want to talk to somebody about it. And this is where the issue comes in. So I think it's about also being able to say, look, if you have any questions, you may not be able to answer, but this is where you can go for answers. But in terms of sharing with children and young people, what I did with mine was I had already spoken to my friend, Rebecca, and I said at some point I'm going to tell my child about my status. So if she has any questions that she can't ask me, is it okay if I tell her to go and ask Auntie Rebecca? And she said, yeah, you can do that. So, and we did that for each other, many of us, and also link them into support where children who had already been told about about their mums or carer status had support. Those days it was at Body and Soul. It was called, there's a group where children who've been told about their parents or carer status. So it's just putting into place where you can then link them into. And I think the other important thing is just about peer support, as I mentioned. If you're planning to tell either a partner or a family member or a friend or a child, talk to other people, talk to other women who've already done it. How did they do it? And just see not everything might work for you, but you can pick something from each of them. So I've been asked this question so many times that I wrote something called the 10 top tips for telling a significant other or a child or a partner that you have HIV. So I can send you a link to that as well. It's just a conversation starter. So I think earlier on you'd asked me about a book or a podcast recommendation. So can I recommend 2 books and 1 podcast? So the first book I'd like to recommend, of course, it would be unwise of me not to do that. It's called Our Stories Told by Us. It is a book that was written, co-authored and co-edited by 5 African women living with HIV who are migrants in the UK. And it is about celebrating the African contribution to the UK HIV response. And we put this book together. It has contributions from African people living with HIV, but also from our allies, because the response has been made as a collaboration of different communities and key stakeholders. What we wanted to do with that book was to change the narrative about how African people living with HIV are portrayed in the media and society. And we wanted to show that actually we're beyond statistics. We are not just victims or recipients of services, but we've actually been contributing to the HIV response in a positive way. The second book I want to recommend, being International Women's Month, is a book by one of my very, very favorite authors, Chimamanda Ngozi Adichie. I've just started reading it. It's literally just hot off the press. It's called Dream Count, and I read anything that she writes. So that's a book I'd like to recommend. I've started it and I'm already getting into it, so I recommend it to everybody. And lastly, the podcast I'd like to recommend is a podcast series by the organization Positively UK. I'd like to particularly recommend the episode which was recorded on the 19th of September 2024. It is interview of my daughter, Malika Chalwe, and my friend Rebecca's son, Kieza Musonda. And they talk about growing up at Positively Women, so growing up with mothers living with HIV. So those are my recommendations.
Next, we hear from Dr. Laura Waters, a leading HIV clinician and researcher who reflects on the progress in treatment and the importance of inclusive, gender-aware healthcare.
Hi, I'm Laura Waters. I am a doctor in sexual health and HIV, and I work and more recently live in central London. I qualified from medical school back in 1998, and I didn't particularly love medicine, but I found my home in the specialty of genitourinary medicine or sexual health, and subsequently have specialised in HIV. I work in a busy HIV clinic. I've done a few things over the years, including being chair of the British HIV Association. I'm currently the National Specialty Advisor for HIV, and I still love my job. So HIV's changed dramatically during my medical career. So we learned about HIV a bit at medical school, not a huge amount. And when I qualified in 1998, that was the start of things getting much better in terms of effective treatment. But I remember doing an attachment as a medical student, which would have been in about 1995, and going to the ward at Chelsea and Westminster. And honestly, being petrified, I'd never seen anything like it. And seeing young people dying of conditions I'd never seen before alone was really, really sobering. And it kind of made me a bit nervous about HIV as a specialty. I remember sitting in someone's clinic, and on the wall was a poster with all of the AIDS-defining conditions all listed out. And the kind of questions that were being asked were, again, just intimidating, because these were young people and they were dying. And obviously by 98, things had started to get better. And then one of my first encounters was actually in about 1999. And I was doing an attachment as a very junior doctor on an intensive care unit. And there was somebody who'd been admitted with pneumocystis pneumonia, one of the common conditions that people with very advanced HIV can have. And this woman died. And there was lots of discussion about should her partner be told. And I guess that's a conversation that still happens sometimes now when we're talking about whether we put HIV on death certificates and things like that. But it was a big, big topic of discussion back then. But again, it created this kind of scary mystery about the condition. And it wasn't until I actually started working in sexual health in 2002 and started doing HIV clinics well into the era when outcomes were much better. But I still had the memory of those earlier times. And of course, many of the people I was seeing in clinic had those memories too. And being able to see people taking treatment, albeit not very nice treatment, and we'd have really long discussions about side effects, and we'd be switching people and prescribing other medications to manage quite complex side effects. And then over the subsequent 20 plus years, the treatments genuinely have just got much simpler, much easier. That's not to say it's easy for everybody. And that's a key part of our role, is supporting those people who do need a bit of extra help. But compared to even those early days of effective therapy, things have progressed so very much, even to the point where we can now offer people injectable treatment instead of tablets. So I think, there's still challenges for everyone, whether they're newly diagnosed or been living with HIV for a long time. I think the challenges for women in particular are accessing the testing and the prevention in the first place. And I think we are good at getting testing and prevention delivered to some groups of people, but much less so to others. And for women, it feels like a really missed opportunity, because in general, women tend to have more contact with healthcare services, in terms of contraception or reproductive planning and that kind of thing. And I think there are lots of missed opportunities in that regard. Then for women who are diagnosed with HIV, I think there are a number of challenges. Now, some women come from communities where they're very comfortable being open about their HIV status. We've got some incredible female community advocates and peer leaders who are very generous in sharing their HIV status. But many women come from communities where that's not the case. And whilst it's not to say that men don't experience domestic abuse and coercion and the like, I think it's fair to say that that's something that's disproportionately experienced by women. And to be in a household where you can't share your HIV status, you can't let anyone find your medication. And for some of those women not being able to navigate prevention, not being able to ask their partner about their own additional sexual partners, I think makes some of them quite vulnerable. And then, of course, women, again, not exclusively women, but on average, women are more likely to be carers. And I think navigating HIV clinics, which by and large remain pretty much 9 till 5. And I think one of the particular areas where it's challenging for women is access to clinical trials, because clinical trials are what drives improvements in care, developments of new treatments. But it'd be quite a time commitment. And I think really it should be a standard that we talk about what childcare support someone might need and that we provide funding for that if it's required. I think it should be more standard that we have research clinics at weekends in the evenings. And there may well be clinics that do, but again, on average, the times tend to be more restricted. And so I think typically women can just have a more complex journey of living with HIV. From a medical perspective, I think the perception often is that, men experience more heart disease and other long-term conditions. And actually it's flipped in HIV, and women relative to men are at particular risk of things like heart disease, but because of the perception that they're less at risk, they may be more underserved when it comes to diagnosis and prevention. I think it's fair to say, well, firstly, it was a woman who discovered or co-discovered, depending on your view, the virus HIV in the first place. I think because much of HIV care in the UK is delivered by people with a sexual health background, and that is a specialty that particularly is attractive to female healthcare professionals, I think it's quite a female-dominated specialty anyhow. And I think that some of the most inspirational leaders in the field, certainly in the UK, have been women. So we look at the British HIV Association, our main national specialty society for HIV, and although it was founded by a man, Professor Brian Gazzard, there have been some really unique and powerful women in that position since. I'm not talking about myself, by the way, although I am one of those women, but Margaret Johnson was the first female chair of the British HIV Association. Indeed, I think she was the first ever professor of HIV medicine specifically, and has done amazing things and still continues to be clinically and research active. Jane Anderson, a whirlwind of passion and knowledge and connections, and has been instrumental to so much. British HIV Association for one, but of course London Fast Track Cities and many other things also. And then Professor Chloe Orkin, who is one of the most inspirational and incredible leaders that I know. Chloe's been absolutely central to inclusion in research and in medicine, and ensuring that we no longer see studies where only 10% of participants are female, and her commitment to representing people of different gender identities and ethnicities and ages is really inspirational. And she's taken that way beyond the borders of HIV medicine and sexual health. A lot of focus on disability, and the fact that somebody so brilliant and so powerful stands up on a stage with her bright blue hair and her rainbow jumpers and just showing everybody that you don't need to look like that archetypal vision of a conformist medical professional to be truly amazing. And of course, the other major area where women really are at the forefront and a true force to be reckoned with is our community, our advocates, our peer support workers, our peer professionals, and people with their not just lived experience, their lived expertise. And there are far too many to mention, but we've got incredibly powerful women with national and international reputations who are their peers, but they're also the peers of those of us who are in the kind of professional tier of what we do, that we learn so much. And the fact that we work so closely together, that we co-produce care it's a real privilege for me as a medical practitioner, and they are truly inspiring. No matter how accessible or empathic or understanding you are as a healthcare professional, you will never be able to provide that degree of understanding that somebody else who has lived through the same situation can. So it's I think too often peer support gets viewed as an added extra, as a luxury, and it's not. It's a core part of what we do and should be embedded and funded as such. So societal attitudes towards women with HIV and how they differ to attitudes towards men, I think more broadly reflects the attitude towards women with sexually transmitted infections in general. and women having sex in general. So there is still, although times have evolved, and the 1960s saw the advent of contraception for women, and there is still a lot of sexist attitudes, I think, when it comes to anything to do with sex and sexually transmitted infections. And I think for men to be sexually active, even to get an STI, can sometimes almost be seen as a badge of honour. And you see clips on television or social media that well, go in there, lad, and whereas for a woman, there's a sense that much more than men, I think, that having a sexually transmitted infection implies that horrible word promiscuity. It implies being like dirty. That's a dirty girl. She's got an infection, and I think there's sorry, that was a noise. I think there's something about that in HIV as well. And I think also when you look at the nature of HIV, that in certainly in the UK, for men with HIV, that's disproportionately gay and bisexual men who have sex with men, which as a community, and again, not exclusively, but on average as a community, that's a very sex-positive community. It's a community that's fluent in talking about sex and sexual risk and sexually transmitted infections. Whereas for heterosexuals, and this applies to a degree to heterosexual men with HIV, but particularly women, is there's not that same necessarily narrative there. And it's still an era when women aren't meant to sort of talk about sex. And I think particularly when we think of some of our older women, and Susan Cole, very well known in the field, gave a fantastic talk at a sexual health conference last year about being not a woman with HIV having sex, but as an older woman having sex, and just the taboos and the judgment that surround that. So I think with age, that men are allowed to age. Men are considered attractive when they age. The archetypal silver fox, your George Clooney's and your Richard Gere's, whereas for women, they are judged so much more harshly. And the same applies to being sexually active and sexually vocal, is this idea that after a certain age, women are past it. And some of that's probably from whenever ago, because it's about reproductive potential, and women are most attractive at their most fertile, and that's going to further the species and stuff. And I'm sure there's some sort of weird biological hangovers there as well. But society judges women aging in a way it just doesn't judge men. And women aren't allowed to look old, but equally they're not allowed to look like they're trying to not look old. You're an actress who ages with wrinkles and you've let yourself go. You're an actress who's had a bit too much Botox and you're desperate. And all of that narrative just doesn't apply to men. And the same is true for sex positivity, like, oh, she's old. I mean, there's been some evolution, and there's sort of, the whole cougar thing, and, that older women can be attractive. But I think by and large, it's still aging sexily is something that men can enjoy more than women, according to broader society. I mean, we know that there's so much inequity in so many elements of the HIV care we provide, and sadly, I'm not surprised that in South London, Black African women are disengaging more. So, what can we do? I think a lot of what we can do, we kind of know already, and it's around supporting people to be able to access care in a way that minimises disruption to their lives. So, be able to come to clinic in a way that means they don't need to explain where they're coming. To be able to offer as much care as we can in settings that are more general, to be able to do blood tests in primary care, to be able to provide care in primary care full stop, to be able to nip to any pharmacy to collect your HIV medication. We have this program, a kind of home care program where private companies deliver meds rather than the meds being collected from NHS pharmacies. As part of that, you can get your meds delivered to Boots, although other branded chemists exist. And there's a Boots store in Piccadilly where a lot of people go. And someone I see in clinic, who happened to be a man, not a woman, but I will get to the point. Someone I saw in clinic, because this is sold as no one's going to know, you're going to Boots, collect any old meds. And this person in clinic someone else said to them, oh, the only people who collect their medication in Boots are people with HIV. So that message, that even this attempt to try and ensure people collect their meds in a setting that wasn't obviously an HIV clinic, there can be indirect stigma perhaps that people just don't think about. This is far too waffly now. But I think we need to ask women. So we need to sit down and we need to do that research. And I think it's always difficult to do the research in people who aren't coming to clinic, because how do you access them? But I think there we just have to try harder. And I think we need to have discussions right at the beginning of someone's care journey. So there's a brilliant study called REACH, which was published a few years ago now. And they asked people, including women, what kind of things would support them to come to clinic. And it was things like supporting payment for transport in advance. It was non-scolding staff. It was, easy access to appointment cancellation and rescheduling, all of those things, but also pre-agreed actions if somebody doesn't turn up. And to sit down with somebody from the beginning and try and anticipate what barriers they might experience. It's similar with adherence to medication. We ask people if they've missed medication in the previous weeks. We're not so good, even though it is in the European guidelines, at asking people for the next 6 months, do you foresee any situations where you might struggle to take your pills or struggle to attend for your injections? I think we need to do the same about attendance. And I think it's going to be very individualised, but there'll be some very common themes. And working with the women and with other relevant services in the immediate community, I think we'll work together to try and make things a bit easier. Again, this is where I think our community organisations are invaluable, because our community organisations can reach the affected communities and can share messages in a way that is clear and meaningful to them. So I think we need to support our HIV community organisations to work with other relevant community organisations, and wherever they can, they do, but they have very limited resources. So I think when we are so dependent on what community organisations do, we have to find a way to ensure they're supported to do that work. But unfortunately, we all know what a financially constrained situation the NHS and social care are in at the moment, and things are getting worse. And how you make that argument, I think, is very challenging, which is why we need to collect as much evidence as possible. But I think getting the message to the communities where it's relevant, there's lots of good work working with religious communities and faith leaders to share messaging, utilising primary care. I mean, a lot of people use primary care services. The London Bloodborne Virus Champion programme for GPs has been incredible, but again, that has cost money and that required investment. And it's brilliant because by having people who are champions for a condition, that increases the potential points of access to non-stigmatising and clear information at different points of access to healthcare. I think similarly, emergency departments, again, sadly, because of the way medicine is at the moment, a lot of people rely on emergency departments for support. So working with local emergency departments, leveraging all of the amazing work that's been done through the emergency department BBV opt-out testing programme, and having information available, having teaching sessions with staff, having champions within emergency departments, nurses or reception staff, who again can just make discussions about HIV and HIV care and prevention just part of what we chat about alongside blood pressure and blood sugars. I mean, it's difficult to ask a seasoned doctor in 2025 what they're excited about services, because right now everything's so up in the air. Like NHS England is disappearing and we don't know what things are going to look like. So I guess I would say that I'm quite excited about the opportunities that yet another restructure are going to afford us in terms of really modernising services for the future. The current government have really committed to single care records, because the days of people not wanting their GPs and other healthcare professionals to know about their HIV are actually relatively in the past. There are still some people for whom that's a challenge, but by far the most common gripe when I see people in clinic is, what do you mean you can't see the result of the cholesterol test I had last week? Why can't you see my blood pressure results from my GP? I'm really happy for that information to be shared. And so actually, if there are the infrastructure and hardware and software changes implemented as standard across the NHS, then that's going to deduplicate a huge amount of work and create massive efficiencies that you can then use to truly innovate services. So I'm looking forward about how we use technology and the right support, of course, to join care up to make sure that as people age with HIV as being just one of the conditions that on average they'll be living with, that we can coordinate things to provide much more seamless and much more holistic care. When it comes to treatments, I think the long-acting treatments are hugely exciting. It doesn't matter how many pills you take for other conditions. Many people with HIV describe that unique fear, that reminder of living with HIV. I've had people say they can swallow all their tablets for their depression, high blood pressure, etc., but they look at their HIV tablets and it's just a whole different level. And if we do reach a stage, there was some data from a conference recently about a drug that could be given once a year. Currently, there's nothing to partner with it. If somebody could have an implant or an injection once a year, and then HIV just becomes something that's still important, of course, but it will make it much easier to navigate some of the other complexities, both physical, psychological, social, financial, all of the challenges of aging. And as our age pyramid in society gets more and more top heavy, we're going to have to think about ways that we support an aging society and to make HIV care as non-complex as possible, to be as confident in long-acting treatments that we don't even need to measure viral load very often. I think that then frees people up to focus on some of the more complex issues.
Thank you for listening to this episode. We hope these conversations spark thoughts, compassion, and action, because every woman's voice in the HIV community matters.